Thank you, Victor. I was saying earlier at lunch that I'm really impressed by how well this entire conversation has been curated, and I appreciate that this conversation follows the previous one because there are many things about education and about jobs that I don't have to talk about because we just covered them, but they're the issues that are also very central to the work that we do in place-based work. My conversation today will address some of those same topics, but from the perspective of a place, of a single place. Let's see. A little bit about enterprise. We had an introduction from Victor about it, but there have been comments about bringing both human capital, and I, of course, now am going to emphasize a little bit about the capital piece as well because I do affordable housing. And Enterprise is a national affordable housing nonprofit that has about 600 folks, and we work both on a national level and also on the ground. I am located in the Bay Area, and so we'll talk a little bit about San Francisco and its particularities. First of all, this is your, a little bit unclear, but typical tourist map of San Francisco. You might get that from your concierge or, I think it's from a rental car. And it points out all those delightful things about San Francisco that I think we can all agree to. There are complaints about the weather, but generally speaking, I think most people have a pretty high association with San Francisco, and it is a really lovely place. Victor mentioned that it has really come to the fore around its economic prosperity, and in fact, 1 in 6 San Franciscans have graduate degrees. 18% of all patents are generated in the Bay Area. It's home to 56 of 300 of the wealthiest people in the world. Starting salaries for coders, and the tech has really moved into San Francisco, somewhere between $150,000 and $200,000. And Twitter alone has created 1,600 millionaires. And because of this, the city itself is wealthy. There is increasing money that's coming into the coffers. And it is a service-rich city. There are a wide array of public services and ones that are really focused towards supporting not only this wealthier class, but also the less well-off. And for folks who have lots of money, there are lots of things to spend money on, and of course, one of those things that they get to spend money on is their housing. And rent, right now, I think the average price for a 2-bedroom is $4,780, which requires an income of $230,000 to be affordable. Okay, so in fact, however, the city continues below the tourist map, and we're going to talk about some parts of the city that are in the lower right-hand side of the city, in the southeast area known as Bayview Hunters Point, and in the Visitation Valley area, for a project that is called Hope SF. And these 4 different public housing developments are located in an area that is geographically isolated from the rest of the city. There are people who have lived in San Francisco their entire lives who have never ventured down to where these housing developments are. They also lack many of the retail and other services that you would see throughout the rest of the city. These are pictures of those developments, and as you can see, they are old, dilapidated, barrack-style public housing. It originally designed and built as shipyard housing, and all of the developments themselves face the shipyard. I guess they were all intended to just watch with their employment their entire time. They were built to last 10 years. They've been in existence for almost 60. The project, Hope SF, was launched in about 2008, and it is the nation's first large-scale public housing revitalization project that was designed to focus on the residents who live there. In your typical revitalization project for public housing, the housing is torn down, residents are given vouchers and sent off, their new neighborhoods are built, and there's an effort made for folks to come back, but the folks who come back are generally not necessarily the ones who have been living in this kind of poverty, this kind of isolation. They're often have fewer barriers to employment, fewer challenges, I say a little less complicated. So the development itself, or the neighborhood itself, is touted as a success, but not necessarily for the residents who live there. So San Francisco made a commitment to engage in supporting the residents who live there in this revitalization effort. So this is a teardown of these original barrack-style units, replaced with 3 times the density, replacement public housing, additional affordable housing, and then market rate housing. So the statistics that I shared with you about San Francisco don't necessarily reflect the statistics of many of the residents who live in public housing. And for Hope SF, this is much more representative. The average household income is less than $14,000, and this is average household size is about 4. In a city that is generally very healthy, with a diabetes rate of about under 5%, they report between 16 and 29%. The chronic absenteeism rate in school, which is being absent from school for 10% of the time or more for any reason in the city, is 8%. And in Hope SF, even at the elementary level, is 53%. There is really considerably more violence in these developments, considerably worse unemployment rates than throughout the city. The 92% unemployment rate relates to transitional aged youth, young people between the age of 18 and 24, but for all able-bodied adults, that unemployment rate is about 73%. So this is where we start. And since this is an effort that is intended to support the residents who live here, meet them where they are, it's meant that we've done a lot of learning. And today, I want to share with you what we have learned in 3 particular areas. There's a lot, as I said. We can talk about the challenges around employment, we can talk about the challenges in education, but in thinking about where the intersection with the public sector is, I want to focus on 3 things. And first, it's that impact of trauma. It's the role that replacing that housing plays, and the catalytic role that philanthropy plays. And I want to emphasize these 3 things because these are areas where the private sector is already involved or could be involved in more significant ways. So when we started Hope SF, we had an appreciation of the neighborhood conditions based on what was referred to as the 7 Corners study. In 2006, the Human Services Agency conducted a study looking at utilization rates of the public services and found that 60% of the families in crisis, so those families that were relying on that had intersection with child welfare, were relying on food stamps that were justice involved. 60% of those that were in crisis lived within walking distance of 7 Corners in San Francisco. 4 of those correlate with these 4 developments. So we knew coming to this that already that there was a number of traumatic events that were impacting the lives of our residents. Then, because we are working with residents and our goal is to ensure that when we rehabilitate or replace the housing, that they are in as good a position as their new housing would represent, we began with a model that focused on community building, working with residents in engagement capacity, Community building is a widely respected form of engaging in communities where there is this kind of isolation. It often involves pulling together folks for different gatherings, of celebrations. It's a way to get to know your neighbors. It's a way to begin to build a community in a place where there hasn't necessarily felt like community that's had so much violence. We found that there was not the kind of uptake in the typical activities as we might have expected. We also noticed that in service-rich San Francisco, the next model that we moved into, which was a service connection model, one where if the services exist and somebody needed that service, that simply connecting that person with that service would lead to success. But that really didn't work. We found that the presence of services and making that connection left a lot of people frustrated. Sometimes the services didn't exactly correlate to the needs of the residents, and oftentimes there were very good services, ones that on paper would appear to match exactly what a resident might need, but just making that connection didn't lead to someone actually participating in that service or taking advantage of that service. We also found that for the service providers who were at the sites engaged in making these connections, that they were experiencing a great deal of burnout. And in fact, we went through a number of different service providers at some of the sites. And up through this point, we found ourselves asking the question, as I think most people do, what's wrong with you? What's wrong with the staff that can't stay and work at these sites? What's wrong with folks that they're not able to connect with the service, that it's the right service? Why can't you connect with that service? What's wrong? And then we had a crash course in brain science. And we learned about the impact of trauma. And this is where things start to get a little bit awkward for me, because you guys are the folks who are in medicine, and I'm the person who works in housing, and I'm not going to talk about trauma. But that's okay. But we did, one of the things that San Francisco is great about, and the Bay Area generally, is that we have a lot of experts, trauma experts. And we were able to call on them to help advise us on how we could begin to think about what was happening in our communities in a different way. And they helped us to understand that we needed to ask the question, what has happened to you, not what is wrong with you. We learned about the neurobiological impact of trauma and how it was those traumatic events that were having a perpetuating effect on the folks that we were working with, and how much those incidences, especially ones that happened in childhood, were the ones that were having such an impact on success in our residents. We also learned about how much all of these traumatic events had an impact on the health outcomes that we were seeing in our adults, as well as just the behavioral issues that were coming up in young people. And we also came to understand that the challenges that we were experiencing around staff burnout was really an issue around managing for the vicarious trauma that folks were experiencing who were working with the families that had experienced so much trauma. I'm guessing that everyone in the room knows much more about what I'm talking about than I do, but that's okay. I'm going to just share with you a little bit about adverse childhood experiences and the ACEs tests that happened through Kaiser and the work that was done there, and the appreciation that these 10 different types of traumatic events are what are measured to understand the impact that trauma may have on a person throughout their life. So in the abuse side, physical, sexual, and verbal abuse, and in the neglect column, physical and emotional neglect, and that there are 5 family dysfunctions that are identified. And I think to me is what is most telling about the research is that a person with 4 or more ACEs, and each one of these is considered an ACE, has significant impact on a number of different areas in a person's life. So a person with 4 or more ACEs is 12.2 times as likely to attempt suicide, 10.3 times as likely to use injection drugs, 7.3 times as likely to be an alcoholic, 2.2 times as likely to have ischemic heart disease, 2.4 times as likely to have a stroke, 1.9 times as likely to have cancer, and 1.6 times as likely to have diabetes. But it also really impacts the executive functioning skills that somebody develops. And so those issues of trauma are the things that I think are the things that Carla experiences when she has young people coming into her programs, and it's the same things that Farad would experience with his young people who are coming in through his educational programs. For us, what has been important about it is being able to put words to it, to begin to understand it for what it is, and not to understand it as only by its byproducts. So within the initiative, we responded by conducting trauma training at each of our Hope SF sites, working with the staff who were there to begin to empower folks there with the knowledge of what trauma is and the impact that it has on folks. We also trained and supported the resident leaders there, so they had an understanding. They could put words to their own experience, and in fact, they were experiencing it very strongly. We developed a peer health leadership program that also allowed for residents to support each other in a navigational way, and really supported the idea of trauma-informed everything. And with that was tweaking the community building model to respond to this trauma-informed understanding. Our public health system also responded by creating a trauma-informed system, and they've been training their entire workforce. And in fact, I'll get to it in a minute, and that as a result of pulling everybody together and coming up with some certain principles that they share broadly. There's also in California, which has been one of 25 states that has conducted a statewide study of trauma. There have been findings that childhood adversity is very common, and in fact, 17% of Californians across the board have 4 or more ACEs. And I think what that means is that not only is it important for this kind of trauma-informed approach to occur within the work that we do on the ground, but it's important throughout our private as well as our public sectors to adopt this understanding, because our residents will be working or hoping to work in these environments and interacting in these environments, and they'll need all the support that they can get. So I'm not going to take the time to go through all of these, but these were the principles that our Department of Public Health put together, just 5 basic principles around a trauma-informed approach. But this is by far one of the areas that we think is an area that is something that the private sector, especially in the health industries, can help us with. So the second area is really houses, and we have a board member who is a doctor and refers to housing as a vaccination, and we move through that perspective. This is one of our first rebuilt Hope SF sites. On the left side, these two coexist at the same time. We did everything in phased development, so families are moving from the left side to the right side. And the impact of moving from a place that is filled with vermin to a place that looks like that is incredible. And the health changes that occur because of that kind of move are really significant. Most people think of, and it is public housing, but most people think of housing and affordable housing as a federal or other public subsidy event, and it is by and large. But in fact, one of the largest providers of resources for affordable housing is the private sector, and it's through the tax code. And there is a way to invest in affordable housing. It's been around since 1986. It is actually one of the ways that we have produced more affordable housing throughout the United States than any other mechanism. The federal government designates credits, low-income housing tax credits, that go to each state. Each state has the opportunity to refine its program. Those tax credits then pass down to the developers where investors invest. There is a requirement that the housing remain affordable. There's a little bit of flexibility at the state level as to how long it stays affordable. And the corporate entity receives a tax credit for 10 years. It's been incredibly successful, to the tune of $2.5 million since 1986, creating over 100,000 affordable units every year. There is really rigorous state oversight, the way that it's created, and it allows the private sector to have a stake in the affordable housing that's being built. So it's really quite a win-win situation. And in the interest of time, I'm going to move on to my third, which is looking at philanthropy and how catalytic philanthropy has been in our initiative. This is a public-private partnership. We have our local community foundation, the San Francisco Foundation, as well as Enterprise, a nonprofit, and then the city of San Francisco as three legs to a three-legged stool, making a lot of decisions and moving through this together. On the fundraising side, we've raised $11 million with a substantial gift from Kaiser at $3 million. It has allowed for us to pay for all of these human capital programs that we've rolled out at each of these sites. Our peer health leadership program, our on-site project-based employment program, as well as our educational engagement and school attendance program. And it really allows us to be innovative. It allows us to go out and research what the best practices are and to begin to implement them in a way that responds well for our residents, that our residents can connect with. And I'd like to give an example about how that's really changed things. As I mentioned before, we had a situation where our residents were known for not using the public services that were available until a crisis level. And with the Affordable Care Act, the Department of Public Health really wanted to figure out a way to connect our residents to a medical home. In addition, we, on the philanthropic side, funded studies to look at the challenges of trying to bring mental health to our residents in a non-stigmatized way. And the outcome of the research of looking at ways that we could bring our non-stigmatized mental health services and pairing with it the peer leadership program that we created and the health navigators, what was born from that is what we refer to as our on-site wellness center. It is taking a vacant residential unit and installing an RN, a person who is really responsible for blood pressure checks and things like that, but with a goal of moving folks to a medical home. But in the process of talking about why your blood pressure is high, you begin to talk about the traumatic events. And then you have a warm handoff to the behavioral health specialist who is sitting in the next room, which begins the conversation, which leads either to an individual treatment or into groups that are created there. And our health navigators are the people who do the outreach on behalf of the clinic and bring folks in. It has allowed our public health system to answer a question that they couldn't answer on their own, and a way to begin to move our city resources in a different way, in a place-based fashion, which San Francisco is not usually equipped to do. Kaiser is in a position right now of helping us to expand this program, take it from something that was just one site where we piloted it to expanding it to all of our 4 sites, and to institutionalize it with our public health system. So, and then we have one coming up. We know that for many of our residents, they have many interactions with many different public systems, and it's a full-time job to be able to see all your case managers. And so our goal is to pilot what we're calling Little 5, Big 5, which is to take 5 families and figure out, just using those 5 families' experiences and their interactions with the public system, how it is we can streamline their interactions and eventually affect all 5,000 being the total number of Hope SF residents. So that's what we're doing on the private sector side. So thanks very much.